this podcast on the female reproductive system, we're going to talk about the uterus and the fallopian tubes, the so-called uterine tubes. We've talked about morphological and physiologic aspects of the menstrual cycle. So, for example, we've talked about the ovarian cycle and how LH and FSH regulate the ovarian cycle. So, for example, the LH surge stimulates completion of the first meiotic division and ovulation. Now, here we want you to appreciate levels of estrogen and progesterone in the blood, and we want you to particularly be able to pay attention to how different levels of estrogen and progesterone affect the mucosal linings in the female reproductive tract, because we're going to expect you to be able to recognize histologically differences between the different stages of the cycle and which hormone would be more prevalent in relation to what you see histologically. Here's just an overview of the uterine tubes, the so-called fallopian tubes. The first region that we talk about is the infundibulum. The infundibulum has fimbriae associated with it, and the oviduct is actually opening into the space of the peritoneal cavity. It is closely approximating the ovary, and this is something that's a little bit unusual. It's sometimes hard for people to appreciate that, but when ovulation occurs, the ovum is released into space, if you want, into the peritoneal cavity. But the oviduct being so closely approximated to the ovary, cilia on the cells of the fimbriae at the infundibulum are moving and beating, and it's creating a current that's almost wafting the ovum into the infundibulum. The ampulla is the longest segment of the oviduct. It's the site of fertilization. The isthmus is the narrower medial segment. It's probably the shortest of the segments. The intramural portion actually lies within the uterine wall, and it opens into the uterine cavity. The oviduct itself is composed of three distinct histological layers. From the inside out, there's a very complex folding, the so-called mucosal layer. There's a muscularis. The muscularis actually has layers of smooth muscle, although those layers are sometimes difficult to distinguish histologically, but generally we say that there's an internal circular layer of smooth muscle and an external longitudinal layer of smooth muscle, and then there's a serosal layer. The epithelium sits on a typical lamina propria, a layer of connective tissue. There are at least two cell types in the mucosa. There's an intercalated cell, which is probably a stem cell for the main cells that are in the oviduct. The cells we talk about as ciliated cells and secretory cells. They're simple columnar cells. The ciliated cells predominate at one phase of the menstrual cycle, and the non-ciliated cells predominate at a different phase in the menstrual cycle, although you'll see in the oviduct these cells intermingled with each other. Is the mucosa of the oviduct, as we said, a simple columnar epithelium. Note the abundance of non-ciliated cells in this portion to the right side of that heavy arrowhead, and the ciliated cells here on the left side. These ciliated and non-ciliated cells are thought to represent different functional states of a single cell type. The cell type is just exhibiting a different phenotype depending on whether it's under the influence of predominantly estrogen or predominantly progesterone. The non-ciliated cells, the secretory cells, are sometimes called PEG cells, and they're given that name because they sometimes appear to stick above the epithelial surface. We have nice examples of that you'll see in the laboratory, these non-ciliated PEG cells sticking above the epithelial surface. Estrogen stimulates ciliogenesis, so under the influence of estrogen there'll be more ciliated cells. Under the influence of progesterone there'll be more of the secretory or PEG cells. The oviducts, as we said, show cyclic changes. The follicular phase is under the influence of estrogen. There's an increased ratio of ciliated to non-ciliated secretory cells. There's an increased rate of ciliary beating, and that would make some sense as you want to capture the oocyte, the ovum, and move it into the infundibulum and on into the uterine tube. At ovulation, the fimbriae that are closely opposed to the ovarian surface, the cilia on them are going to beat very fast and rapidly, and there'll be peristaltic movement that's going to transport the ovum towards the uterus. The luteal phase is under the influence of progesterone. Here there's an increased ratio of non-ciliated secretory peg cells compared to the ciliated cells. The uterus receives the morula from the fallopian tube. As you know, the uterus is the site of embryonic and fetal development. In a woman who has not given birth, the uterus weighs about 30 to 40 grams. It may be something like 7.5 by 5 centimeters by 2.5 centimeters thick. The body of the uterus has a large upper portion. The anterior surface is flat. The posterior surface is rather convex. The fundus is the uppermost rounded region. The cervix is in the lower portion of the uterus. There's an internal os which communicates with the cavity of the uterus, and there's an external os which communicates with the vagina. Now, the internal and external os are anatomically defined regions. It's not so easy to tell histologically whether you're looking at the internal or external os, although you can get some sense that you may be near the external os when you look at a transition in surface epithelial cells, and I'll talk about that in just a second. The uterine wall has 3 layers. There's an endometrium, which is the mucosa. There's the myometrium, which is a thick layer of smooth muscle, and there's the perimetrium, which actually is rather thin. It's consisting of a mesothelium and a thin layer of loose connective tissue. Here's just a histological view through a section of the uterus. So you can see the very thin perimetrium. You can see a very thick myometrium like this, and you can see blood vessels in the myometrium. And here is part of the endometrium. What we're defining here is just a blow-up of the endometrium. And this is an important point now to understand both histologically and physiologically. The endometrium can be divided into a stratum functionale or functional layer and a stratum basale or a basal layer. Histologically, they look a little bit different based on the structures that you see, and they respond to hormones during the menstrual cycle quite a bit differently. The functionale is a layer that gets built up during the early part of the menstrual cycle. It's being prepared to receive a fertilized egg for pregnancy. It's also the area that's sloughed off during the menstrual cycle. The basal layer does not change dramatically during the menstrual cycle. You can appreciate the flow of blood coming in from the myometrium. You have these uterine arteries that branch into arcuate arteries, and then a radial branch which forms these straight arteries that are supplying the stratum basale. But from these arteries you also get spiral arteries that come up into the functional layer. Here, these arteries break down into large, we call them lacunae. They're just large spaces or sinuses that are very rich in blood. Here you can see the epithelium, and then you can see these uterine glands, which are invaginations of the mucosal surface. And these uterine glands can be very long and straight, and they can eventually branched into the stratum basale. The nature of these uterine glands is going to change dramatically during the menstrual cycle. The myometrium, 3 indistinct layers of smooth muscle. The smooth muscle structurally and functionally is a syncytium. All 3 layers work together during contraction. This is something that I find very interesting. Smooth muscle cells are up to 50 microns long in a non-pregnant uterus. The same cells can be 10 times longer, 500 microns long in a pregnant uterus. So not only is there a lot of cell division, but there's considerable growth in the individual smooth muscle cells during pregnancy. Now, as we said, the endometrium undergoes cyclic changes that follow the menstrual cycle to prepare for implantation of the embryo. We've suggested there are 2 functional zones of the endometrium during the reproductive life of a woman. The stratum functionale, the functional layer, is the thickest portion. That's the portion that changes during the monthly cycle. It's the portion that's sloughed off at menstruation. The stratum basale, the basal layer, is retained during menstruation. That layer serves as the regenerative source for the cells in the functional layer. Let's go back to this cartoon. So here we now want you to appreciate the changes that are going to be occurring in the endometrial lining in relation to the levels of these different hormones, estrogens and progesterones. Here are some histological views. On the right is the menstrual phase. Here is the proliferative phase, and here is the secretory phase. The dotted line, so a dotted line here would show the stratum functionale, the stratum basale, here the myometrium. Here in the secretory phase, look how much more pronounced the stratum functionale is in relation to the stratum basale, and then the menstrual phase, the stratum functionale is being sloughed off. Here on the bottom are just higher power views of the stratum functionale. Clearly, I want you to be able to look at how the differences are in the uterine glands. Look at how long and straight the glands are in the proliferative stage. Look at how coiled and corkscrew the glands are in the secretory phase. And here in the menstrual phase, you see lots of profiles of large blood vessels. You see the mucosal surface just breaking away. Here's an example of the proliferative phase of the uterus versus the secretory phase. Look at the long, straight glands in the proliferative phase. This is under the influence of estrogen. Here, the glands are very much curlicue or squiggled, coiled. This is the secretory phase under the influence of progesterone. So you're going to want to be able to identify histologically these two phases and be able to distinguish them on glass slides. Let's talk about the cervix and the vagina. The endometrium of the cervix differs from that of the rest of the uterus. The cervical mucosa is 2 to 3 millimeters thick. The cervix contains large branched glands. The cervix lacks spiral arteries. There's minimal changes to the cervical mucosa during the menstrual cycle, and the cervical mucosa is not sloughed off during menstruation. The cervical glands do undergo functional changes during the menstrual cycle. These changes are important for the transport of spermatozoa. The changes reflect the amount and properties of the mucus that's secreted, and this is under the influence of ovarian hormones, and there's a coordination of ovulation and cervical mucus properties during the menstrual cycle, and that makes fertilization much more likely to occur. As you know, the vagina is a fibromuscular tube that joins the internal reproductive organs to the external environment. The vagina has numerous mucosal folds. It's a stratified squamous epithelium on the surface. The epithelium does show cyclic changes with the menstrual cycle. There's a continuous desquamination of the epithelial cells, which happens to increase during menstruation. The underlying lamina propria in the vagina consists of a loose to dense irregular connective tissue. There are lots of lymphocytes and leukocytes in the epithelium and in the lamina propria. These cell numbers increase during menstruation. The deeper connective tissue layers contain many thin-walled veins, and these deep connective tissues with the thin-walled veins actually serve as erectile tissue in sexual arousal. The muscularis has intermingled layers of smooth muscle. There's an inner circular and an outer longitudinal layer, but that's sometimes difficult to pick that up histologically. Here's a diagram of the cervical canal. So the internal os would be here, the external os would be here. So this would be vagina, this would be the uterus proper. There's a transition zone right in the area of the external os, and that transition goes from a layer of simple columnar cells in the cervical canal to a stratified squamous epithelium that line the wall of the vagina. You can see these glands in the cervix, and these glands are going to have expanded cysts called Nabathian cysts. Those are sometimes visible histologically. Let me show this in a histological view. So here is the cervical canal. The area of the external os may be here, so the vagina would be down near the bottom of the screen. This would be some of this cervical mucus. These may be some of the profiles of these Nabathian cysts. So you can see this zone of transition, a stratified squamous epithelium on this area of the vagina to the simple columnar epithelium in the cervical canal. And here you can actually see that transition point, the simple columnar epithelium to the stratified squamous. Here are some of these cervical glands. Here is this stratified squamous in the region of the vagina. And here is the vagina with a typical stratified squamous epithelium, just a higher power view of the mucosal surface. You can see lots of blood vessels in this connective tissue that's below the stratified squamous epithelium, and then a little bit deeper you can see some of the muscle layers. The cells are very large. Note they're not keratinized, so the nuclei appear all the way to the cell surface. The cells in the vagina are actually very large, and they're actually look like they've imbibed a lot of fluid. Metaplastic changes are common in the transition zone of the cervix. As you know, metaplasia is an adaptive and reversible change to an epithelium due to persistent injury. So here just shows simple columnar epithelium and then metaplastic stratified squamous epithelium that's occurring in this region of the cervical canal. In the cervix, metaplastic changes can be precancerous, as epithelial cells will get reprogrammed to follow new cell lineage pathways. Now, cervical epithelium tend to be constantly exfoliated into the cavity of the vagina, and that exfoliation forms the basis of the Pap test to screen for cervical cancer. And here is a normal Pap smear on the left and an abnormal Pap smear on the right. As you look at these two images, I wonder if you can tell the difference between the normal versus the abnormal Pap smears. Look at the normal smear. Look at the large flat epithelial cells and the very highly pycnotic nuclei. Look on the abnormal smear. Some cells have the pycnotic nuclei, but look at these other cells with very large expanded nuclei, suggesting that these cells could be precancerous. HPV infections are also relatively common. HPV is the most common sexually transmitted disease in the United States. It will infect the urogenital and anal areas of women and men. There are more than 40 different types of HPV virus. HPV targets dividing cells, hence the cervical mucosal epithelial cells are prime targets for this. Now, the images on these slides, you don't have to know this, but they're from in situ hybridization of a biopsy of cervical epithelium with a DNA probe to two forms of HPV that cause genital warts. I don't care that you know that. As we said, most HPVs do cause genital warts, but there are two types, HPV 16 and HPV 18 infections. These infections have a 70% risk of cervical cancer. They also can cause cancers in the anal area and the vulva and in the penis. So men are not immune to getting these HPV infections, and as a sexually transmitted disease, they may pick up the HPV from their partner. As you know, there have been recent developments of vaccines against HPV viruses, and it's good medical practice now to inoculate both young men and women against the HPV viruses.